after all these years that I've been knowing her, she is very cool. And this morning, she will be speaking on cool things that we have learned from the treatment of retinoblastoma and what is the future. May I present Carol?
Thank you. It's been a great pleasure to be here with you in Thailand and discuss retinoblastoma. This symposium is really outstanding, and it's reassuring to me to see how much progress that you've made here in Thailand. So I'd like to talk to you about cool things in retinoblastoma and giant leaps that we've made in the field of retinoblastoma. In North America, the management of retinoblastoma is chemotherapy. It's all about chemotherapy. First, it begins with an accurate diagnosis. You've heard that already today. Retinoblastoma can look like other pediatric eye conditions. Here we see the classic leukocoria of retinoblastoma, but about 25% of cases sent to us with the diagnosis of retinoblastoma don't have retinoblastoma. So don't ever prescribe chemotherapy based on a phone call. This kid has leukocoria, what should we do? Don't ever do that. Look at the patient yourself and establish that it is retinoblastoma. Jerry alluded to this. We looked at a series of 2,775 patients referred with the diagnosis of retinoblastoma. 78% had retinoblastoma, 22% did not have retinoblastoma, and the leading diagnoses included number 1, Coats disease, 2, persistent fetal vasculature, 3, vitreous hemorrhage. And if you look at it based on age, it slightly differs. For example, if you look at the itsy-bitsy 0 to 1-year-old children, the most common pseudoretinoblastoma is persistent fetal vasculature in 49% of cases. But then as you look at the older groups, those over 1 year of age, between 1 and 2, it's Coats disease. And 2 to 5, it's Coats disease. And Coats disease. And overall, it's Coats disease. So really keep that in mind, that it differs based on the age of the young baby. So here I show you 3 kids all sent in with the diagnosis of retinoblastoma. The child on the left has retinoblastoma, and you can see the calcified mass in the eye. Coats disease that can look like a macular retinoblastoma, but there's no feeder vessels, and there's no calcification on ultrasonography. And then persistent fetal vasculature with the classic ultrasound stock. Sometimes, though it's difficult, we see retinoblastoma versus Coats disease, both with total retinal detachment. The first thing I look at is, I look for telangiectasia when I see total RD. Then I look for these light bulb telangiectasia, and I look for vessels that are dipping into the tumor. You see vessels dipping into the tumor on RB, and you see telangiectasia on Coats disease. You can always get an ultrasound to differentiate the calcified from the non-calcified globe. So let's now talk about chemotherapy. We have different ways to give chemotherapy. Intravenous, intraarterial, intravitreal, high risk, and we don't use subtenon's chemotherapy anymore. Intravenous is known as chemoreduction. Dr. Rajanporn talked about this. This has very few complications if you use it right and you dose it right. Intraarterial is exciting. We use this quite a bit in our practice. We use intravitreal only for vitreous seeds. Some people talk about using it for other things, but just for vitreous seeds. And high risk to prevent metastatic disease. Subtenons used to be used, but we don't need it anymore because intraarterial chemotherapy has replaced it. We've also heard about the International Classification of Retinoblastoma. For those of you new to the field, you can read this nice current opinion in ophthalmology about the basic understanding of this new classification. Basically, we have A, B, C, D, E. I can recite this to you from my mind because it's so simple. A are small tumors, as illustrated here, less than 3 millimeters. B are bigger tumors, greater than 3 millimeters, or those in the macula or with fluid, like this one with subretinal fluid surrounding it. C have contained seeds localized to the tumor. D has diffuse seeds far from the tumor. And E is extensive disease greater than 50% of the globe, or those eyes with opaque media or NVI. Okay, how do we choose which chemotherapy we give? Beginning with intravenous. chemoreduction. I give credit not to the U.S. for chemoreduction. I give credit across the Atlantic Ocean to Judy Kingston at St. Bart's Hospital. She was the first to use chemoreduction. And then 3 centers in North America used it: Toronto, Los Angeles, Philadelphia, all at the same time. And we all published it at the same time. In the Archives of Ophthalmology, 1996, we all had a positive experience. This chemoreduction has revolutionized how we treat retinoblastoma nowadays. We use the Philadelphia protocol: vincristine, etoposide, carboplatin, 6 cycles, all children get the same. Here's what happens. They get the first dose of chemo, and it causes the tumors to shrink down. And then we consolidate each tumor with thermotherapy or cryotherapy. And note that I'm sparing the foveola here. I never apply any therapy to the foveola, because you can get away with skimping on the side of the foveola. Here's the tumors immediately after treatment, and then long-term they remain under control in most cases. So we looked at the International Classification of Retinoblastoma, and it does predict chemoreduction success. For group A, B, and C, we have 90% or better success, 47% for group D, and less for group E. Now a few words about intraarterial chemotherapy. We use this for primary or secondary retinoblastoma, unilateral or bilateral disease. We most often use this for primary unilateral retinoblastoma or for bilateral retinoblastoma if they fail chemoreduction. We use melphalan, topotecan, and we no longer use carboplatin. Too toxic, too many complications. When do we use and how do we use these medications? If it's a newborn baby, melphalan 3 milligrams. If it's an older baby, standard is 5 milligrams melphalan. If it's someone who has previously been treated and has failed, we give them the big dose, 7.5 milligrams melphalan. We never go higher than that. When do we use topotecan? If there's vitreous seeds, because this hangs in the vitreous for a long period of time. Carboplatin, don't use it anymore. What am I showing you here? We as the ophthalmologists mark the forehead of all of our babies because the neurosurgeon doesn't know which eye to do. Don't ever risk the neurosurgeon or the interventional neuroradiologist guessing which eye to do. I think we're the only center that marks the forehead. Here I'm telling them, use melphalan 5 milligrams, topotecan 1 milligram. We plan 3 cycles. Each cycle takes 1 month. We use a neurosurgeon. I can talk to you about that later. Others use interventional neuroradiologists. This kid's getting melphalan 7.5 milligrams, topotecan 1 milligram, because he's failed other chemotherapy. You can see the tegaderm on the surface so that it doesn't get rubbed off. And I always sign my orders at the time I mark the forehead so there's no mistakes in these kids. Dr. Rajanaporn showed you the different ways we give it. This is direct catheterization right into the ophthalmic artery, but not really. I can take that with questions. And here we have the balloon catheterization where we indirectly go into the ophthalmic artery. So we compared intraarterial and intravenous chemotherapy. We've now treated 680 eyes with intravenous chemotherapy and 260 eyes with 800 infusions of intraarterial chemotherapy, and we have a lot of experience. So I'm going to show you the comparison. Intravenous chemotherapy does well for A, B, and C. Intraarterial chemotherapy does well for B, C, and D. But it wins when you compare D eyes. Intraarterial chemotherapy does better than intravenous. We did a head-to-head comparison of the two, intravenous versus intraarterial chemotherapy, published in the Asia-Pacific Journal of Ophthalmology. And in this, we found that intraarterial chemotherapy does significantly better for group D eyes and for solid tumor subretinal seeds and vitreous seeds. So it really outbeats intravenous chemotherapy. But they look pretty much the same. On the left is a plate of intravenous, and on the right, intraarterial chemotherapy, showing before and after. You really often can't tell which therapy the child has received. And in that head-to-head comparison, again, we found group D significantly does better with intraarterial compared to intravenous for unilateral. Why is this important? Because most unilateral retinoblastoma is group D or E. So that's why we need to know which is better. Here's an eye with group D retinoblastoma before and after 2 doses of melphalan. IAC out-trumps IVC. That guy agreed. I don't know if you guys are giving him a thumbs down or a thumbs up, but it doesn't matter. We're stuck with him. So here's an eye. What would you do? It seems like this tumor is mostly nasal, like maybe there's a little bit of temporal area of the fundus that doesn't have tumor. We said let's give intra-arterial chemotherapy. There might be a little normal retina up there. Look what we found. We found a macula. And then we did OCT, and the fovea is okay. And guess what? The child has 20/40 vision. So this is when it's really important to use intra-arterial chemotherapy. How young and how old can we go? We usually go down to 3 months of age, and we don't know. We can go up to really old patients. 6 to 7 kilograms is our limiting factor. We did a 2-month-old. This child had regression nicely, and this was a 32-year-old with newly diagnosed retinoblastoma. That's his tumor, and it responded nicely. But we use it for 13q syndrome, and I don't have time to get into all the specifics. We use it for children who fail chemoreduction, showing the failure here, and then after intra-arterial, the cleanup. Another failure with hemorrhage. After intra-arterial chemotherapy, we actually have a little bit of a macula here. So I'm going to skip to the very end because I want to talk about some toxicities. Now that we've gotten to be a little bit better with intra-arterial chemotherapy, the serious side effects have lessened. With experience, you can reduce your serious side effects of choroidal vascular atrophy, retinal artery occlusion, ophthalmic artery occlusion to less than 2% of cases. We have seen no cases of stroke, metastasis, or death, but we're very careful in how we handle these kids. And know that melphalan can cause infertility. More than 7 cycles in a male could produce infertility. So you really have to think about your dose that you're giving to these kids. Intravitreal chemotherapy, Dr. D has talked to you about this. It's important to inject through the pars plana, cryo as you remove, and jiggle the eye. We always rinse with BSS to get rid of the chemo that might have leaked out. This child came in from Jordan. It was her only eye. Massive vitreous seeding. And you can see after some injections, we got some control. And then we actually got complete control with intravitreal chemotherapy. And we were happy to see that there was the macula and she had vision behind all those vitreous seeds. Last, a comment about high risk. This is when you enucleate an eye and you find that the tumor has grown post-laminar or into the choroid. Enucleation is not the end, it's the beginning. You have to look at your pathology and see if the child has high risk. And these kids are all put on intravenous chemotherapy. Swati Kaliki showed that intravenous chemotherapy can prevent metastatic disease. If you don't put them on that, they may have a 24% risk for metastatic disease. We have not had anyone in Philadelphia die from metastatic retinoblastoma in over 19 years. Enucleation is still used. I know some people have approached me and said that's their only method of treatment. So to conclude, how do we decide which chemo that we use? Well, it's based on laterality and classification. If a patient has bilateral retinoblastoma, we tend to use intravenous chemotherapy for many reasons. If it's unilateral disease, we tend to use intra-arterial chemotherapy, or if it's really advanced, enucleation. The classification of retinoblastoma does play into our choice of therapy. Thank you.
Any question for the audience for Professor Shields?
Carol, I have one question. Have you ever combined the IAC and the IVC together?
Yes. So for children who come in with really advanced group E retinoblastoma, bilateral, we plan 6 cycles of intravenous chemotherapy to shrink the tumors in the eye, protect them from metastatic disease, and we hope prevent them from getting pinealoblastoma. Then at the end of their IVC, we give them a dose or 2 of IAC to both eyes to prevent recurrence. So hopefully at some point in the near year or two, we will actually put those cases together. Really advanced disease where you get both treatments.
Another question, have you ever had any incidents of extraocular extension after intravitreal injection?
No, we've not seen any extraocular extension after intravitreal injection, but we have seen complications. For example, when you inject too close to the lens, you'll get a cataract. If you inject too close to the iris, you'll get iris atrophy or uveitis. With posterior synechii, then your pupil doesn't dilate. If you inject too close to the retina, you'll get RPE modeling and hemorrhagic retinitis. So we like to inject directly mid-vitreous. We go right in mid-vitreous, and we always try to make our injection same clock hour, because if we happen to get RPE atrophy, we only want to sacrifice 1 clock hour of the retina with RPE atrophy, because we know that's going to play into vision loss down the road.
The last question, why did you stop carboplatin?
So it was early on when we started using IAC. We were using melphalan, topotecan, and carboplatin, but we had a few instances of occlusive retinopathy. And we perused the literature, and we found that carboplatin, especially when it's used for brain tumors, often can cause occlusive vasculopathy in the brain. So we just cut out carboplatin.
Okay, last speaker is Dr. Rich. Dr. Rich is here. He's going to talk about